G'day everyone and welcome. Marsh and Macquarie University are very proud to host this online seminar on the family impacts of repetitive brain injury. I'm Dean Mumm, I'm a risk advisor and insurance broker at Marsh and also a former Wallaby, having played 12 seasons of professional rugby union.
Welcome, Dean. I'm always slightly awestruck to be in the presence of a Wallaby. And I'm Dr. Rowena Mobbs. I'm a neurologist leading the work into concussion and CTE at Macquarie University Hospital and MQ Health. So thank you everyone for joining us sincerely here today. Dean, we've got quite a lineup, don't we?
We do. And we're going to start off, we've got a number of supporters to run through. We'd like to thank Marsh, Swiss Re, Brain Injury Australia, Glia Diagnostics, Fujitsu, GE Healthcare and the Men of League. We're now going to take you into a welcome to country.
Yama Warami Willimbimbi Warami Midiga Warami Daruga Nura Warami Walameta Warami Wanura Walametical. We welcome you on behalf of the ancestors and we acknowledge all of the elders past and present. We acknowledge all Aboriginal nations of Australia. We walk together on this land and we pay respects to the traditional owners and those who have walked before us. We acknowledge the land's history, yesterdays, todays and tomorrows. The land speaks of the Darug and their dreaming. We can still feel, hear and see the ancient songlines across this beautiful campus. This land has held many gatherings for centuries, since the Darug's first sunrise some 60,000 years ago. We belong to the land. We are many nations, many people, coming together, looking after this country and respecting each other. We stand here together at Macquarie on sacred ground. As the Wallamai navigate the mangroves and find their pathways, so shall you here at Macquarie. Warami, welcome to Wallamata Juju Goyanu.
I'd now like to extend a very warm welcome to Mr. Walter Kmet, Chief Executive Officer, Macquarie University Hospital and Conjoint Associate Professor. Walter has a deep understanding of healthcare operations, systems and policy. He continues to lead the hospital in integrated care and initiatives to improve both the patient and population levels of healthcare. He's also on the advisory board of the Australian Centre for Value-Based Healthcare and a member of the Ambulance New South Wales Advisory Board. Particularly relevant for our discussions today, he holds a Level 1 referee qualification with Football Federation Australia. So a very warm welcome, Walter. Thank you.
Thank you, Rowena. Hello, my name is Walter Kmet. I'm the CEO of Macquarie University Hospital and Clinical Services. On behalf of MQ Health, it's a pleasure to welcome you here to today's seminar. We are proudly supporting Brain Awareness Week with a number of events. Can I thank our team and partners for organising this timely seminar today. This virtual seminar will discuss the impacts of repetitive brain trauma and efforts being made in advocacy, collaboration and research. We will hear from well-known sporting personalities and others representing industry and service providers. Their collective efforts in creating better awareness is essential for better outcomes for those affected by brain injury. In this regard, it is also important to recognise that some of the biggest impacts from brain injury are evident in families' perspectives and concerns. Families may be struggling in their own roles as they care for loved ones with brain injury. Strengthening the system to support them is an important part of the picture. Symptoms of brain injury may be hidden for many months or years before a person reaches for help. Here at Macquarie, we have committed to making a difference through caring, teamwork and innovation. We are also committed to continue to engage with all of you to advance our collective impact with an objective of alleviating, even one day significantly reducing the impact of repetitive brain trauma, most notably arising from contact sport. Led by Dr. Rowena Mobbs and Macquarie Neurology, MQ Health offers the expert care needed to ease symptoms of brain injury. Is it also a desire to be compassionate towards families who are suffering and work with them to support sufferers? We will continue to pursue investment and the application of latest technology and research to better identify signs of CTE in our athletes today. This work nationwide has great significance, and the findings, particularly through the findings of CTE in the brains of retired sports people. It also informs us to the importance of creating a safe environment today and for future generations of sport people. Again, on behalf of MQ Health, we welcome you to today's seminar.
Thanks, Walter, and thanks to MQ Health for hosting us here today. I'd now like to introduce a concussion in sport video featuring Australia's leading Australians in politics, sports and media, who will provide commentary on repetitive head impacts in professional and amateur sport and some of the personal and family impacts that follow with them. I think what it will see and what you will show is how we as a nation have a duty of care to our athletes. Speakers included in this video include the Honourable John Howard, Alan Jones, Nick Farr-Jones, Peter Fitzsimons, Steve Blocker-Roach and Jeff Fenech.
Well, sport is part of who we are as Australians. It's part of our national cement. And I'm doing this video interview because I'm a passionate sports follower, as many people know. I follow both codes of rugby, rugby union and rugby league. In my younger days I played both, and I also played soccer. And the reason I'm doing this is that I want parents to feel that the participation of their children in body contact sports is as safe as it can possibly be. And the concern about concussion is not born out of hostility to sport. It's actually born about a desire to make the playing of sport as safe as possible.
You know, I want to see people, and particularly young people, participate. So if there's hindrances to that, to mum and dad saying, yes, I want you to play a sport, even if it's a collision sport, we have to look very, very closely and seriously about protocols that are put in place that give parents in particular the comfort that, yes, there can be some collisions, yes, there may be a one-off head knock, but the sport that my child's playing is on top of the issues. The coaches are well educated and we as parents are well educated.
Firstly, I think we've got to get things right, and therefore we need significant debate about this rather than alarmism, because we're not going to stop people from playing sport, and we're not going to stop mums and dads from wanting their kids to be in sport at school and everywhere else. So we don't want them to be alarmed to think that every time they engage with someone in a contact sport, they are at risk of significant damage. So there's not enough homework being done on that. On the other hand, I think it is acceptable to say that a lot of what passes in sport most probably has the potential to put people at risk.
I feel it very personally. You know, I suppose I'll look a little bit at the rugby generation ahead of me, 2 generations ahead of me. It worries me a bit. You know, a few wallabies in their 70s, and I go, well, I mean, the normal population, I guess. The non-rugby population has issues in their 70s, but I keep track of it, and if you look at erratic behaviour, and sometimes you see rugby league players, you know, lately particularly, I guess I've been watching it, erratic behaviour, seriously erratic, sometimes violent behaviour in men from whom you don't expect it. Now, I don't know, and I don't name any, but there is a growing pattern, I think it's fair to say, across all football codes, where we start to realise when you have erratic behaviour from men in their late 30s, 40s, it's that kind of behaviour. You look at it and go, well, there's a damage being done. On a bad day, I feel like there's an epidemic coming down the pipes, because footballers these days are bigger, faster, harder, and going for longer than they ever did before. And in my day, people would get a knee injury and they'd be out for 6 months, which gave their brain 6 months rest. These days, too often, keyhole surgery, and they're back out there a week or 2 later, and it's just relentless.
The other thing for me too is denial. I was in denial for a long, long time, just, you know, forgetting things and, you know, talking sentences and like forgetting words during what you're trying to talk. I don't want to see people suffer. I mean, you know, I've got a lot of mates who have had a lot of concussions and all that sort of stuff, and, you know, to see them with their families and to see them not even wanting to get out of bed to go and to do a job.
There are guys I used to box, Steve, I used to punch their heads in every day. And look, today, I might sound fine that, but there are days block that I do something and 30 minutes later I forget it, or I organise to do something at 12 o'clock and it's 11:30 or quarter to 12, it's 12:05. God, I'm supposed to be somewhere. I just forget. I mean, look, I don't want to put anybody else in that position.
We need to continue research. We need to get to the bottom of the things that are doing the damage. And I don't say we shut down football. I think that the overall benefits of all football codes far outweigh the damage done. But the thing we need to raise kids on, and particularly kids coaches and kids parents in sport, is if in doubt, sit it out. If you've got your bell rung, as they call it, if you can see sparkles in front of your eyes, if you're feeling an otherworldly experience because you've headed a ball, you've hit your head hard, a knee's come into your head, all of these things, it's not just shake it off and get back out there.
As we go forward with, sort of science and testing, and, as we look at statistics now of the impact of a lot of collisions as people get older, particularly, the rugby and the AFL, type sports, where you're now seeing people maybe, sort of suffering from issues like dementia and what have you, maybe at an earlier age. There needs to be a lot more work and science done in that.
Well, no, anybody who suggests I'm anti-sport that doesn't know me. I'm pro-sport, and it's because I'm pro-sport I want the playing environment to be as safe as is reasonable. It's a body contact sport. People are going to get hurt, people are going to get uncomfortable, and they're going to break their limbs here and there. We understand all of that. But we also understand that the long-term consequences of concussion can be serious, and we want to see, everybody wants to see the issue challenged and dealt with, but dealt with in the context of promoting sport, not censoring sport.
In a good game of rugby league and rugby union and Australian rules, whatever, you play into space. You want the boy running into space, not into someone. So the collision stuff, if you think that's a risk, I'm saying don't play. It's absolutely stupid to think that you're sending a kid out there to bash up against another kid. That's not what sport's about. And we've got to redefine all this. Coaching's got a lot to answer for. We're not in the business of collisions. We're not frightened of engagement. And there's a referee there to make sure that it's a legal rather than an illegal engagement. And we're not going for the head and so on. There's a lot of good refereeing about that at the moment. But I'd like parents to think that their children were safe. But I think that it's not just parents and administrators, everyone's got a responsibility.
But I would say to parents in particular, don't be fearful, don't worry. They're two things that go against, what I believe is faith and hope. Yes, I've had 4 kids that, from time to time have had knocks and what have you, and yes, it does worry you, but if there are strong protocols in place and your child's not rushed back into sport, then you shouldn't worry and you shouldn't fear. It doesn't mean that just like when your child goes out and drives a car, it doesn't mean that there's not a risk out there, but it's a calculated risk.
So I think the laws can be changed without alarming people to limit that kind of heavy engagement, head on head, body on body, big fella on little fella. Go and enjoy yourself. Tell them to enjoy themselves, but I think a parent needs to be very responsible in supervising anything that might be untoward that happens in the playing of the game.
Absolutely has to be more research. There has to be research and there has to be a growth in awareness. And anybody that can help, camera one on me, anybody that can help to raise the funds for the research, please do. In terms of ruck for your buck, it doesn't come better.
I want sports participation to be widespread and safe, and that is what this campaign is all about.
Well, I'm sure you'd agree they were very profound videos from our leaders across politics, journalism and sport, and I greatly thank our leaders for their input and advocacy for the research. I assure the country as researchers we are pro-sport as well, and we'd like to find that balance between safety and play for our future generations, so thank you. I'd in particular like to thank Mr. Lee Hatcher, renowned broadcaster and journalist who has assisted with these videos. I'd now like to introduce our next video, which is one of our major initiatives here at Macquarie University to help care for patients and also their families who are suffering from repetitive head trauma. So we're going to hear about Concussion Connect, which is one of the more successful strategies we have engaged in to help people on a day-to-day level, help them understand and share their stories together, but also guide them with expert-led neurology and neuropsychology. The work goes on every second month or so. If you want to find out more, you can contact Macquarie Neurology. Enjoy.
My expertise is in helping people understand the relationship between their thoughts and their emotions and their behaviours after a known or suspected injury to the brain. Understanding what's going wrong, so pinpointing the areas that are not functioning as well as they used to, and then out of that, promoting a discussion and a generation of strategies that can help that particular individual.
It's almost a relief to know that other people are experiencing the same things that I am. It's been such an isolated experience up until now, but now I know other families and other partners are navigating it the same way that we are.
So this was my second one. The first one was brilliant because I walked in, I had no idea what to expect, and the couple of the guys were talking and I was just nodding my head, and it was such a relief to listen to people like them and go, wow, I'm not the only one struggling, I'm not the only one who's had this, to the point where I then insisted that my wife came down, because at this point I think my wife needs more help on handling me than I need the support.
I think it's important that friends and family are provided with the relevant education to understand what's happened to their loved one, and that understanding in and of itself sometimes might be enough for them to take a less judgmental approach, so that their family member doesn't feel as though they're being blamed or as though they're constantly doing something wrong.
What you do and just take for granted down the track you're not going to be able to do. And I actually don't know what day of the week it is. You know, I literally get up, get dressed, get ready to go to work. Oh, it's Sunday, go back to bed.
When I retired, I was in denial about a few of the issues that I was suffering from, and it took me to hit rock bottom to realise those.
My family have medicals and they don't recognise it, so they were like, oh, it's only an emotional thing, these headaches are... And I was just like, no. And then when I started suffering from anxiety, I phoned them up and said, now this is anxiety. Well, you know, there is a huge difference here.
I think people want to deny it because they're worried that if they personally don't recognise it, then it'll go away or it's not right, and they're probably fearful. And when there's a time when I think it's a bit noisy or you need time away, and it's just a place where you can go and just have, there's a chair there, come on, and so you can just go through, or if it's a meditation or just listening to an audiobook.
I'm really calm and whatever, and then because of the head injuries, you sort of go out and they've made a mess, and your mouth opens, and then you just go. And you went back into the bedroom, calmed down, and I've been doing yoga and meditation. I think that is helpful.
It's much easier to prevent it than it is to manage it once it's happened. Because once it's happened, it's all negative. I think either way, it's important for a person to develop some awareness of how their behaviour or how their memory difficulties are impacting on the people around them, because that's the first step in actually doing something about it.
We have found that this has been the most therapeutic thing we could have arranged for our patients, and they have really thrived in that environment of connecting with others. The families are finding it beneficial, they're getting a lot of practical help on day-to-day levels. So with any brain symptoms and brain conditions, it's really hard to understand what someone's going through and what type of sometimes subtle but certainly very impairing symptoms that can occur.
Seek some help, go to your GP and get a referral on, and of course go and see a neurologist and then see about connecting into it.
Here's help that you could go to get support. So to stop one person committing suicide, this group is fabulous.
I'd like to sincerely thank everyone involved with the Concussion Connect program, most especially our patients and their families who are very brave in participating in that video, but helping to show that help is at hand, particularly focusing on one of our first values, the healing aspects here at Macquarie University. I'd now like to introduce Dr. Ryder Leichstadt, a research fellow for the Australian Institute of Health Innovation at Macquarie University. Dr. Leichstadt is an injury epidemiologist with a particular interest in sports injury, traumatic brain injury, and combat sports. His research is centred around conducting large population-based cohort studies using data linkage to investigate health outcomes following injury and really to guide health policy and improvements on a broader level. So thank you so much, Ryder. Cheers.
Thank you very much for the introduction, Rowena. So in recent years, there's been a lot of attention around contact and collision sports and chronic traumatic encephalopathy, or CTE for short. But CTE is not the only neurodegenerative disease that has been linked to traumatic brain injury. So today I thought I'll try and give you a very, very quick rundown on what we know and what we don't know about TBI-related neurodegeneration. So firstly, CTE is a distinct neuropathological disease. There's now broad consensus around the neuropathological criteria for this disease. But part of the issue is that definitive diagnosis is only through neuropathological examination of the brain tissue after death. In terms of the clinical syndrome that precedes death, it's less definitive and it's highly reliant on diagnosis of non-specific symptoms such as headache, migraine, mood and behavior changes, and so on. So to drive this field forward, there is a great need to identify objective biomarkers such as blood tests and neuroimaging to further refine the diagnostic criteria for the clinical syndrome that precedes, that is associated with CTE. Unfortunately, there are many, many unknowns when it comes to CTE. We don't know how many people are living in the community with CTE at present. We don't know the extent of the burden of this disease, nor do we know what the lived experiences and the unmet health needs are for patients that are living with CTE. And we don't know how much head trauma is required to develop CTE in the first place, and we don't know the thresholds in terms of the TBI severity or the cumulative impact that's required to develop CTE. So to answer some of these questions, we definitely need a large data sets to further this field. Let me move on from CTE specifically and talk a little bit about a few things related to other neurodegenerative diseases. There's not a lot of data available, but there have been two fairly large studies published in the recent years looking at neurodegenerative diseases and mortality from those diseases related to professional football players. These two studies have been looking at American football and soccer respectively. So what did these two studies find? In a nutshell, compared to the general population, former professional football players are about 3 to 4 times more likely to die from a neurodegenerative disease. In terms of specific neurodegenerative diseases, former football players are about 4 times more likely than the general population to die from neurodegenerative diseases like ALS, dementia, and motor neuron disease, and about 2 times more likely to die from Parkinson's disease. I think it's quite remarkable that the risk is this high, given that football players and athletes in general otherwise are much more healthy than the general population, with a less risk of dying from common diseases such as cardiovascular diseases and cancer. So although participation in sport is generally really, really good for us, we really need to do a lot better when it comes to protecting athletes' brains. So to summarize, traumatic brain injury is a leading risk factor for neurodegenerative diseases and associated mortality. It's been estimated that perhaps as many as 10 to 50% of dementia cases in the community are related to traumatic brain injury. But we don't know the extent of the societal burden of traumatic brain injury-related neurodegeneration. And we really need to establish new studies and gather large data sets to be able to answer some of the questions related to traumatic brain injury and related neurodegeneration. Thank you.
Thanks, Dr. Lysted, and thank you for providing some insight on what the data shows at the moment as a former professional athlete. Not all rosy for me, but it does go to show that we need to investigate far more and do a lot more research. I'd now like to introduce a friend of mine, Nick Sorden, Head of Casualty Underwriting at Swiss Re. The Swiss Re Group is one of the world's leading providers of reinsurance, insurance and other forms of insurance-based risk transfer, working to make the world a more resilient place. Thanks for your time, Nick.
So today I just want to briefly cover how the industry deals with new exposures like concussion and CTE and what we think about this. So new risks creating exposures and potential claims is something insurers have dealt with regularly since the start of the industry. There's a broad landscape of new or emerging risks that insurers have to deal with and reinsurance partners need to consider. So new risks creating latent or long-tail injury issues like concussion always create broader challenges given the longevity of the claims. Now, insurers love data and historical claims information is really crucial to the operation, and it's largely how insurance premiums and coverage is determined. When it comes to developing risks like those presented by concussion or mild traumatic brain injuries, and furthermore the larger chronic neurological injuries, there's no past experience that insurers can rely on to support risk underwriting and pricing. Now, when people think of concussion or CTE, often their minds turn to professional sport, and there's no doubt that the largest media attention is in that segment. However, this could be the tip of the iceberg. And if just staying with sport for a moment, there are many more players and participants at the amateur, school, community, and youth sports clubs level, as we heard earlier from some of the presenters. And therefore, those clubs and their associations are actually keenly exposed to future claims from concussion. So are local councils, schools, event organisers, medical first aid staff, equipment manufacturers, and possibly even coaches. And all of these can have an impact on families, as is the point of the discussion today. Now, at its heart, it's important for insurance companies that their clients and customers manage their own risks as well as possible. Whilst, of course, there's a vested interest for insurers regarding a reduction in claim payments, insureds or people making claims often means that something bad has happened. So if insurers can support that with advice, information and guidance, it's better for everyone. Now, some in the insurance industry consider concussion to be the next asbestos. Asbestos was one of the largest issues the insurance industry had to face, especially when it comes to latent injuries and claims. And this is why sometimes concussion is referenced to asbestos. Now, that may be an over-dramatisation comparing to asbestos, given the multi-billions that have been paid out in asbestos claims. But there are much wider implications than just sport. And some say that once CTE diagnosis and other long-term injuries are able to be established pre-mortem, this could significantly change the risk landscape and the potential for future claims. As this seminar focuses mainly on the impacts to families, I see insurers playing a crucial role in assisting here to ensure that sport can continue to be as safe as possible. In conjunction with experts, insurers providing appropriate advice and guidance to their insureds and their customers to manage their own risks better is fundamental. Therefore, we fully support the work done by Macquarie University and the further study and research and scientific development in repetitive brain trauma impacts. Given brain injury concerns, some people believe there is also an expiration date on contact sports. I personally have a different view, and I also see that the benefit of sports participation are absolutely clear. And I think that, and my own son plays rugby, and given my knowledge on concussion, I still feel there are safe aspects to play around rugby and other contact sports. So I think there will be a certain change to certain aspects of the games and sport in general with regard to rules and the framework around practice, for example. And from an insurance standpoint, greater awareness, education, better management, better protocols, systems in place, and awareness is absolutely key to the continuation of safe sport. As I mentioned earlier, insurers need quality information to ensure that we can continue to offer appropriate coverage at an affordable price and an affordable premium for all aspects associated with sport. So this is a brief example of how insurers and reinsurers consider concussion and these long-term injuries potential. And hopefully this gives you an insight as to some of the aspects we consider when we're looking at these new and developing exposures like concussion and CTE. Thank you very much for your time.
Thank you so much, Nick, and it's absolutely wonderful having your insights and knowledge in insurance industry for us as researchers. As you can see, it's pretty essential that we do cross over into industry and insurance and work together as a team, so really thank you for those insights. I'd now like to introduce a really important aspect to our work, one of our major themes, looking at domestic violence and head trauma. And what we can see around the country yesterday is that there's a lot of feeling towards women's advocacy, and rightly so. And I see this as part of that effort. We need to help identify who is suffering domestic violence-related head trauma and get them better services and better research. So I'd particularly like to thank our couple, Rachel and Scarlett, for sharing their experiences. And thank you for watching.
I experienced a lot of violence throughout my childhood, and that involved quite a number of head injuries, right from when I was very young. When I was 13 was the first time I saw any medical professionals, and that was after a suicide attempt. But I didn't get any real help. It was only in my 20s that I started regularly seeking and being turned away from medical services. Because people see my file, they see marks of self-harm, and it destroys my legitimacy. It made me feel worthless.
We met in an art therapy group for women with complex PTSD. I think what brought us together was love. When I heard Rachel's story, I felt resigned because it's a story I've heard before. I felt furious, I felt terrified, I felt lost and like it was us against the world. People need to listen to her and pay attention and care.
What Scarlett and I have together is probably why I'm still here. It's made all the difference. Head injuries from domestic violence are repeated and cumulative, makes it more serious.
I think doctors need to know that when it comes to head injuries from domestic violence, every time they turn someone away, they are risking their life.
Everyone counts, and every time it's more significant and more dangerous.
Then we found Dr. Mobbs, and for the first time, it was like someone was taking Rachel seriously.
At first it felt too good to be true, that here was someone who actually saw me and thought I was worth helping.
For the first time, someone was interested in the invisible impacts that domestic violence have had on Rachel's brain.
We're hopeful that with her as an ally, we've got a way forward.
That was extremely poignant, and it really makes me think about what is best care as a doctor. And I think sometimes the first step is to simply listen and be there with a patient in need. But by sharing their experiences, I think Rachel and Scarlett are starting these discussions. I know that Nick Rushworth, who I'm about to introduce, is continuing the work for domestic violence-related head trauma research and care. And this is the beginning of good things, I'm sure, going forward to help these patients in need. It is a pleasure to introduce Nick Rushworth, and he is Executive Officer of Brain Injury Australia. Nick has been head of BIA since 2008, and in 1996 Nick suffered a traumatic brain injury as a result of a cycling accident. Before joining Brain Injury Australia, Nick worked for the Northern Territory Government in setting up their new Office for Disability. He was formerly a producer with the 9 television network Sunday program and ABC Radio National. Nick's journalism won a number of awards, including a Silver World Medal at the 2003 New York Festival and a National Press Club and TV Week Logie Award. Nick's primary focus is facilitating community of practice in brain injury for the National Disability Insurance Agency, being piloted in Sydney. So thank you very much, Nick.
Thank you, Rowena. As you know from what you've just heard, I'm not nor have I ever been a clinician or a medical researcher. What I think I have to offer over the course of the next few minutes are some fairly mundane observations combined with joining the dots towards raising one or two questions. Starting with, if you observe 2 kids fighting in a playground, 2 adults fighting in a pub, there's something instinctive, almost primal about going for the head in pursuit of violent advantage. And nothing I've heard or read in the last several years of working on this particular subject, this particular cohort, convinces me it's any different behind closed doors in the domestic and family violence context. I'll start by talking about an instance of severe traumatic brain injury, but then to go on and focus on so-called mild, chronic repeated traumatic brain injury on a number of assumptions. The first is that women and girls are particularly vulnerable to concussion and susceptible to longer recovery periods and greater symptom loads. Optimum best practice return to sport, whether it's to competitive play or to training, should only take place once a person is considered genuinely asymptomatic. Unfortunately, victim survivors of domestic and family violence who've sustained a brain injury seldom have the luxury of choosing when to return home. This seminar wouldn't be happening if it wasn't for the interest in the potential cumulative impact of multiple mild traumatic brain injuries, what used to be called Box's dementia and is now called chronic traumatic encephalopathy, or CTE, as you've heard discussed earlier. I want to end by raising a question, no more, no less, about the gendered incidence of dementia. I want to start, though, with the story of Rebecca Scarolli. This story is told with her permission. I like to think that Brain Injury Australia's advocacy efforts and awareness-raising efforts arise from the ground up and contact from people like Rebecca, one of 300 inquiries that Brain Injury Australia receives each and every year by phone and by email. We were contacted by Rebecca, who at age 25, just having graduated as an arts therapist, was repeatedly attacked by her stepfather with a claw hammer and sustained a severe traumatic brain injury as a result, had to learn to walk and talk again, requires daily physiotherapy to unlock a painful and paralysed hand. But where the rubber meets the road, as it were, in brain injury is in the cognitive area, and Rebecca continues to have difficulties with organisation, planning, thinking, concentration and memory. Rebecca was involved in the New South Wales launch of Brain Injury Awareness Week in 2005. The national launch was held in Geelong that year, and I like to think in my quiet moments that the reason why the Royal Commission into Domestic and Family Violence held a community consultation there was because of the media and surrounding attention for the national launch, which resulted in recommendation 171 of the Royal Commission's report. Brain Injury Australia was commissioned by the Victorian Government to complete this research in association with a consortium comprising No to Violence, Domestic Violence Victoria, and the Centre for Excellence in Child and Family Welfare, and injury epidemiologists at Monash University. The results, and this report is available to download from Brain Injury Australia's website, but I'm also more than happy to send you a PDF via email via the contact details on the last slide. These are, as it were, the headline findings. 2 in every 5 hospitalisations involved traumatic brain injury. The overwhelming majority of domestic and family violence-related deaths involved brain injury. Half of major trauma cases and hospital admissions involved traumatic brain injury, and a third of hospital and emergency department presentations involved traumatic brain injury. I thought, as the consortium lead for the research, it was important to keep the recommendations to a minimum. They're perhaps unsurprising in the sense that there's recommendations for the provision of information resources, certainly for the addition of screening questions in regards to brain injury for domestic and family violence services. Importantly, there'd be nothing more soul-destroying or sterile or unproductive for an organisation like Brain Injury Australia to have screening questions included only for a woman or a child or an adolescent to screen positively for brain injury, but with nowhere to refer them to that's got genuine capability in the disability. And lastly, to develop and map services and supports that are relevant to the disability as part of the implementation of a genuine nationwide system and service response for this particular cohort. I should say that Brain Injury Australia is eagerly seeking partners and funding in each and every jurisdiction for the implementation of these 4 recommendations. As dramatic as those findings are, it's really all tip and no iceberg. I should say that it was a hospitalisation study, and there are 2 radically under-ascertained populations as part of the research. The first is Aboriginal and Torres Strait Islander communities. This was a study published in the Medical Journal of Australia back in 2008, 43,000 hospitalisations in the Northern Territory, South Australia, Western Australia and WA. And what it found was, of those 43,000 hospitalisations for head injury due to assault, the hospitalisation rate for Aboriginal and Torres Strait Islander women was almost 70 times that of the rest of the population. There was also, as part of Brain Injury Australia's research, again, under-ascertainment of anoxic or hypoxic brain injury due to deprivation of oxygen supply to the brain from non-fatal strangulation, but we are hoping to gather better research results, better data on that in future research. As I was saying, really this report as a hospitalisation study was all tip and no iceberg. The study that I always quote in this area was done in Arizona back in 2016 with 5 domestic and family violence shelters. What it found was, for 115 women, 9 in 10 had reported a head injury with loss of consciousness at the hands of a partner or ex-partner in the preceding 12 months. And of those, again, 9 in every 10 reported, quote, too many head injuries to quantify over the course of their lifetime. But, and this is the important fact, I think, in regards to Brain Injury Australia's study, only 1 in every 5 of those women went anywhere near a healthcare setting. So it raises the question about the real community incidence of not just acute brain injury, but chronic repeated brain injury, the result of serial neurotrauma at the hands of a partner or ex-partner. So Brain Injury Australia has a background of doing work in the sports concussion area. We were engaged in a collaborative campaign with Sports Medicine Australia built around the 5 R's of concussion: recognise the injury, removal from play, referral to a doctor, rest and then return to play. As a result of that research, it became apparent to us that, again, women and girls experience concussion at higher rates than male athletes. A massive study done over a decade in the United States found that of all the sports studied, concussion was most common in girls' soccer than any other sport. Female athletes were 50% more likely than male athletes to sustain a concussion. They were more adversely affected by concussion than male athletes, reported more symptoms, and took almost double the time to recover from their concussion. The other thing, and this is the last slide, I want to raise the question about the potential cumulative impacts of multiple mild traumatic brain injuries. The prestigious Lancet Commission on Dementia only last year added traumatic brain injury to its list of modifiable risk factors for dementia, and what they found was one or more traumatic brain injuries, regardless of severity, increased the risk of dementia almost by a factor of 2. This is a relatively under-researched area. The only study that I can find in recent times was of 40 Canadian women with Alzheimer's disease with histories of spousal abuse with head trauma matched with a community sample of 40 women without that kind of risk exposure. And what it found was the odds of Alzheimer's disease could be 4 times higher in the group with exposure to spousal trauma than for the rest of the population. Which in turn, in my mind, again, nothing more or less than raising questions. In Australia in 2018, there were 230,000 women with dementia and 190,000 men. By 2056, that's predicted to rise to 590,000 women and 510,000 men. In 2016, dementia became the leading cause of death among women, and women now account for 2/3 of dementia-related deaths. Again, I'm not a dementia expert either, but it's always been my understanding that age is one of the greatest predictors of the onset of dementia, and women, Australian women, outlive men by around 4 years. But maybe there are other explanations for differential exposure, differential incidence of dementia by gender that has something to do with the community incidence of domestic and family violence. That is where you can find Brain Injury Australia. Brain Injury Australia's 1-800 number comes through to my mobile phone. So I'm very easy to find, and thank you for your time and attention.
Thank you, Nick. Some absolutely startling stats in there, and on behalf of all of us, thank you for the work you do in that space with brain injury. I'd now like to introduce Professor Gary Brown, Clinical Professor, Emergency Medicine, Children's Medical Hospital, Westmead. Gary Brown is a Professor of Emergency Medicine at the University of Sydney. He's been in clinical practice for 40 years, and he's been the Medical Director of the Kids Concussion Service since 2006 and the head of the Mild Traumatic Brain Injury Research Laboratory at Children's Hospital. Thanks for your time.
Thank you. Yes, we've really been managing concussion mild traumatic brain injury at the Children's Hospital for well over 15 years. And what I'm going to share with you are some of the concerns and some of the responses we've actually had to those concerns. They've been mostly parental concerns over that period of time. I am going to show you videos, and these videos have been given the consent of the parents as we go through this. So, kids' concussion is actually common, and in fact it's the 3rd most common presentation to the emergency department at the Children's Hospital. We think that sport actually accounts for the vast majority, but in fact now we're finding that recreational activities account for probably about 60% of what we see. Yes, it's a simple bump to the head or it's a knock to the body that causes a shake to the head. But the most important sort of thing that often parents don't understand is how their child gets hit matters. And in fact, it's really sort of, if you like, that boxer's punch where the head and neck actually rotates on the shoulder, that rotational force that actually causes particular concerns in relation to injury. And in children, we know that the wiring is actually quite immature, it's developing, and particularly children with attention deficit disorder or with learning difficulties, they're quite vulnerable. And also because of the children's gross anatomy, they actually tend to have a lot of falls. So parents traditionally know that there is the clinical syndrome that we call concussion, and they are the headaches and the dizziness and the concentration difficulties. What they often don't know is that in children it can take up to 24 to 48 hours before those symptoms actually manifest. So again, we need to be fairly cautious there. Further, there is the invisible injury that often we don't really sort of see, and often most parents don't understand, and that's the disruption to brain physiology. So concussion is really a problem of brain signalling, really sort of the brain components of the brain, one talking to the other, and that's often why many of us who are concussed are often slowed down. And I really liken this to the fact that, in fact, our basic energy levels following a concussion are quite low, and the things that we could normally do without even thinking about it, you know, reading a book or moving around, really sort of take a huge amount of effort and a huge amount of energy. So again, here we see that the mobile phone sort of battery is sort of, you know, less than sort of 25% charged. But most importantly, we really do emphasise that concussion is a brain injury, and that's often something that's well forgotten by parents. And the most common important aspect of this is actually recognition. So again, here's Charlie. Charlie actually came to us about a month ago playing basketball. And I like to think of, you know, how you respond to an injury on the field or an injury on the basketball court in I guess, 3 levels. There are 3 basic responses to a concussion. The first is this an emergency? So here you saw that Charlie was off his feet. Charlie was not only off his feet, but he actually didn't get back up on his feet. So clearly we need to actually have a first response here. The ABCs, and call for help. And often what we've found is parents have been quite reluctant to actually become involved here, which is probably a natural thing, mostly because their sporting club or the place they're playing doesn't actually have an emergency action plan. So they're not sure what to do, and they don't really know who to call and where they should get help from. If, for example, Charlie got back up on his feet, then this could possibly be a concussion. And again, as Nick has already intimated, if you think this is a concussion, you've recognised a problem and you need to remove that player from play, and they should really not go back. There's a third response to actually injury, and that might be that there's no injury at all, and we wouldn't really expect parents to make that call. That's really important for a parent to actually be aware that this is probably a call for a general practitioner or a medical person to make down the track over the next few days. So again, the child is actually up on their feet, as we hopefully can see here in this video, which is not quite working, that's okay. So this is really a video of a new sport. It's actually called cheering. And this particular athlete actually fell down, hit their head, and was actually back up on their feet. And again, the issue is, what do I do now? So you need to actually pull that athlete over to the side, allow them to cool off, and you need to evaluate them for a possible concussion. So in response to a lot of parents saying, well, look, I don't really know what to do. There's a whole range of symptoms, and there's a whole range of questions I need to answer. We've actually developed an app which you can actually get in the Apple iPhone sort of app service, and it's called NeuroCover. And the first part of NeuroCover actually allows a parent to actually ask the child specific questions and specific responses that determine if they have a number of symptoms or a small number of symptoms, and if this is a significant injury as well. Most parents are probably not going to move sort of further beyond that, but if, for example, the parent is the coach, or if this happens at school, for example, and it's a teacher coach, as we can see here, this app then sort of, in fact, takes the child and takes the parent through a well-structured process of evaluating concussion deficits. You can actually see here this young man, if the video works here, this young man is actually being evaluated for a balance problem. So again, sort of following that sort of more sort of definitive assessment, we can not only determine if the child has significant symptoms, but we can also determine if there are specific concussion deficits. And then we would move into a concussion action plan. And I'm going to talk a little bit about the concussion action plan in the next slide. The most important thing that the app actually highlights is that if you have identified that there's a problem, there is no same-day return. That child is out, and that child actually needs to get evaluated over the next few days. They do not go back and they do not play their sport. So, the concussion action plan. The concussion action plan is based around, I guess, the standard sort of dogma that we understand in terms of concussion recovery. It's rest and supportive care. What we mean by supportive care is we treat headaches if we need to. It's a stepwise progression towards progressive activity that's below symptom threshold. So we can see here that we have the red zone and we have the green zone, and the green zone is where, you know, the child will have a few symptoms in doing certain activities, but the symptoms really are not so so severe and they recover quite dramatically once they rest from that activity. And again, we stress same-day return. So what we've done, and again, I don't expect you to sort of look at this in great detail, this is quite a busy sort of component of the slide, but we actually have a colour-coded concussion action plan which parents can move through. This can actually be done at home, and it's basically, it's very structured and it takes them through a very structured, progressive sort of course towards recovery. So red means sort of, you know, the child still is acutely unwell, moving into orange and yellow zone and then ultimately moving into the green zone. These are actually readily available on our website, the Kids Health website. Not only can you get the action plans, but there's a whole range of aftercare instructions as well that parents can have. I guess the most important thing to understand about this, and this is something that parents don't seem to understand, that progressive sort of return to both sort of physical and cognitive activity is both reprogramming the brain, and it's progressively sort of regenerating the brain in terms of energy levels. So it's overcoming that brain fatigue as well. So in fact, it's the most effective thing they can actually do to help their child recover. So sometimes it really doesn't all go to plan. Mostly, you know, up to sort of, 75, 80% or more of cases, most children will recover within 4 to 6 weeks. But there's about 15% who will actually have ongoing issues. And again, as already been implied, this was a young girl who was playing football. It was her second concussion. She actually sort of rolled over another player and basically sort of just had florid, overwhelming concussion symptoms. In fact, she had symptoms virtually within every domain of concussion. And really this is quite significant post-concussion syndrome. And really what we've got here in that sort of red curve, if you like, is how we would expect the symptoms following a usual concussion injury to really extinguish very rapidly over time. So over a week or so, we would expect the symptoms to have virtually disappeared. This young girl, virtually a week or two after the injury, her symptoms were florid and they were actually quite overwhelming. And in fact, I've got a little bit of an exercise component there. When she moved around, it actually exacerbated her symptoms and made them much, much worse. So we decided to put this girl into a study that we're currently sort of undertaking, and this study is actually looking at axonal injury. And this is a DTI scan. It's an image that actually looks at sort of water and the way it's sort of positioned, if you like, in axons. And in this girl, she actually had significant frontotemporal white matter injury. And we're actually finding a lot of particularly our female concussed athletes who have quite significant post-concussion syndrome, or patients who are just progressing with their symptoms and not recovering, seem to have this significant axonal injury. We also believe at this point in time, because we still actually have to, we're starting a formal study, that there is some degree of neuroinflammation that's probably making this worse in many of these patients. And so this kind of is, I guess, an important concept, because at this point in time, we're not sure how these patients segue, I guess, into more the dementia or the CTE sort of group, but it is a concern, and these patients really do need to be monitored very carefully. So this final sort of slide is really just saying that we can mitigate risk. Helmets don't prevent concussion, but they do prevent extracranial injury. As you can see, this young man sort of fell, and in fact, hopefully this works, that's actually his helmet. Why do I show you this? A quarter of children we see at the Children's Hospital with a concussion have an associated extracranial injury. So they have a fractured cheekbone. They have a significant laceration to their scalp that actually requires surgery. They might have a significant fracture to their nose. So by simply wearing a helmet, they can actually prevent that. We've also seen, unfortunately, at the Children's Hospital during COVID, that a lot of kids haven't been wearing a helmet, and we've actually seen some very, very nasty and very severe head injuries as well due to this. So I guess the most important message for parents, and I guess parents can actually breathe a sigh of relief by this message, that the best prevention really is good concussion care. So again, if we actually recognise, if we remove, if we allow the child to progressively and gradually sort of recover and get back to their usual level, if we just cautious and monitor them as they're doing that, we're actually going to have the best outcome for our kids. Thank you.
Much. Thank you, Professor Brown, for those really great, insightful comments, a really animated discussion, I'm sure you'd agree. And part of Brain Awareness Week is good, accessible healthcare. I think the NeuroCover app and these approaches are accessible for parents and athletes to participate in, and thank you for that exciting research. I'd now like to introduce Professor John Magnuson, Professor of Radiology at Macquarie University. He's completed a PhD in nuclear medicine and biomedical engineering. He was pivotal in establishing Macquarie Medical Imaging and has more than 120 publications. He's leading our neuroradiology research into CTE, and we thank him greatly. This type of work takes a lot of time, detail, and it is expensive. So it is part of our call for funding is to support these sorts of neuroimaging studies. So thank you very much, Professor Magnuson.
Hello, my name is John Magnuson, and I'm going to be talking to you about medical imaging in traumatic brain injury. First of all, we have to think about when is it useful to do imaging with traumatic brain injury. And in the acute setting, we use CT brains commonly because they're fast, easily accessible, and very safe in the trauma environment. It takes only a few seconds to scan a brain and to generate the types of 3D image that you can see on the slide with, in this case, unfortunately, a depressed skull fracture. When we need to get more information, though, we have to start doing slightly more complicated examinations, such as a CT angiogram. In this case, we've injected dye and we can show the vessels in the neck, often affected with neck or brain trauma, and look for a dissection or breakage in the vessel. And from a functional assessment, we can inject contrast through the veins into the bloodstream and see where it goes and how long it takes to get there. In this case, there's a dramatic difference between how well perfused one side of the brain is to the other. And in the unfortunate setting where we might be considering brain death, this is a way of determining how much blood flow is truly getting through to the brain. In the subacute setting, MRI begins to be used because it takes longer to acquire but gives far more detail, as you can see in this image where there's beautiful delineation of the grey and the white matter in the brain. And this is used to give very good anatomical imaging, gives us the structure of the brain and shows it what it looks like. And when we want to do assessment for hemorrhage or bleeding into the brain, we use special techniques like, in this case, a gradient echo scan. And all of the black areas are where there's blood that has been deposited. These can often be very subtle on normal MRI and won't be seen at all on a CT scan. So already there's quite a bit of additional information that can be given in the subacute setting. Chronically, we might consider doing a structural analysis. So for instance, here are 4 images, top left to bottom right, showing gradually greater degrees of atrophy of the hippocampus, part of the memory structure of the brain, and it commonly decreases in size and is used as a marker of severity in things like Alzheimer's disease. Unfortunately, for the most part, we use an eyeball scale where we have to give a rough estimate of what it's like, and this is not a terribly reproducible technique. We can go on and we can do metabolic assessments, so where we can inject different PET or positron emission tomography tracers into the brain and see where they go to give us information about what's going on within the brain. So what are the challenges? We need to be able to detect important changes earlier. The graph here shows the model for Alzheimer's disease, but the same applies in the traumatic brain injury unless it's catastrophic, where we have normal or pre-symptomatic situation, the bottom left, and we know that things are going wrong. We've shown in other studies that repeated minor injuries to the brain are definitely doing damage, but we don't have the techniques using standard imaging or even functional assessment to work out that that's going on. Unfortunately, as time goes by, the patient moves from left to right into the prodromal phase, and you can see that some clinical markers like cognitive performance will decline, but still we're not very sensitive. By the time they've gone through to full-blown dementia, unfortunately, it's obvious to everyone that things have gone wrong. So the challenge for us is to move the diagnosis to the left of the graph, to see what is going to give us the most value to make early diagnoses and therefore intervene. How can we predict those who are at risk, and how can we better predict outcomes? So there are a lot of techniques that people are trying. For instance, fiber tracking, as is shown here, diffusion tensor imaging, lots of fancy terms to look inside the structure of the brain to see if we can get an insight as to why one particular person suffers more or why one particular person recovers better. The Human Connectome Project has done amazing work looking at how the brain connects together and how this might be changed with traumatic brain injury is one of our challenges. And then, of course, we need to look at how we can assess response to treatment. Pictures like this from the language network showing specific interconnectivity in the brain. It makes sense for us to look at that, to work out is the language or semantic analysis parts of the brain more affected. But unless we can delve into the brain function of people before they're severely affected, it's very challenging to work out what's going on. And then, of course, we have to exclude other diagnoses. So, for instance, in this case, each line is a different classic type of dementia, which we've mapped out using radioactive glucose on a PET scan. And we have some tools for telling them apart, but what we would like to be able to do is do this earlier and more reliably and work out what the patterns are related to traumatic brain injury. So then where do we begin? We need to do a better job with baseline imaging. We're great in the acute setting. We can do CT scans like the one shown here, and we can show the catastrophic intracranial hemorrhage like the one shown here. But when it comes to delving deeper and doing a standardized approach for MRI, for structural and functional imaging, and even PET scans in selected cases, we're not there yet. Experience overseas, in Europe and in the US, has shown that a population-wide standardized approach is the only way that we're going to be able to delve into and solve some of the puzzles which are present with traumatic brain imaging. We need to do a better job at following up. At the moment, in the acute setting, we image, and then often we stop. So we know we need more regular and more sensitive imaging. And we have to be able to correlate that with the progress and the outcome of the patients so that we can look back. We can push to the left-hand side of that graph and work out who is at risk and who we can treat early, who will need more treatment so that they can better respond. And finally, we need to treat traumatic brain injury like a disease worth diagnosing rather than just excluding. Because by the time we are making late diagnoses, we're not modifying the outcome. Thank you for taking the time to listen to this brief introduction to medical imaging in traumatic brain injury. There's so much more that we can talk about, but in the end, we need your help for us to answer these questions.
thank you so much, Professor Magnuson. I think my head's buzzing after all that information, Dean. But we certainly need all this range of expertise in our research and also our clinical care for patients here at Macquarie. So thank you very much. And Dean, I think it's been a fantastic seminar, don't you?
It's been amazing. As a non-clinician here, my head is definitely spinning, so I 100% get that. But what you do get is a sense of how broadly repetitive head trauma is in the effects of it are in the community. And what we've really got to do is look at that more closely. So, Rowena, I think you've got a call to action for us.
We sure do. And thank you firstly to Marsh Insurance as well for their support, as always. And thank you to all our supporters. So our call to action is more support, more partnership and more funding. We've got a SNAP CTE study which is trying to find answers around the risk of CTE and then hopeful care and prevention or management. So we need around $5 million funding to kick that off over 5 years in around 500 patients. So anyone that can help us do that work, we'd be ever so thankful. Many of our patients are pledging their brain to the research as well to match the neuropathology. So thank you for any support, Dean.
Final thank you from us, but to you guys that have been there watching, thanks for your time today. We really appreciate it. Finally, a thank you to our sponsors once again, to Marsh, to Swiss Re, to Brain Injury Australia, to Glia Diagnostics, to Fujitsu, which hopefully I say better than Tubby Taylor, GE Healthcare and Men of League. Thank you again and have a wonderful day.
Thank you.